So we're going to go on and talk about the adaptations during pregnancy, continue talking about adaptations during pregnancy, and we're going to move on to our first section is changes in appetite, food intake, and GI function. So about 50% of women experience an increase in appetite during pregnancy and an increase in thirst during pregnancy. So almost all women experience a change in appetite and food intake, and at least half of them are experiencing an increase in appetite and thirst. This tends to lead to an increase in food consumption and an increase in fluid consumption. And to a certain extent, that is entirely beneficial since there is an increase in caloric needs and nutritional needs during pregnancy, which we will get to. The changes in thirst are thought to be a result of the effects of HCG early in pregnancy. HCG, as you remember, decreased the osmotic threshold for thirst, and this is especially obvious early in pregnancy. The effects of estrogen and progesterone also, excuse me, also tends to affect appetite. And it tends to be go in opposite directions. Estrogen tends to suppress appetite, while progesterone tends to stimulate appetite. And very early in pregnancy, and throughout the majority of pregnancy, with the exception of the last few weeks, progesterone levels are much higher than estrogen levels. So the net effect for at least half of women is a stimulation of appetite. However, as pregnancy continues and as the baby gets larger, you tend to see a decreased tolerance for large meals in advanced pregnancy. So women tend to compensate for this by having, instead of having large meals, having many smaller meals and snacks. Now, at least 2/3 of women also report having changes in their desires for food, so food cravings and food aversions. Now, the changes in food cravings and aversions is due to a lot of things, including just psychological factors, just your tendency to believe that women should be desiring certain foods during pregnancy. However, there is also a physiological basis, a very real physiological basis. So generally for women, they experience during pregnancy a decrease in taste bud sensitivity. So their cravings are often very flavorful foods, so foods with very high intensity flavors like pickles and cheese, or any other foods that tend to be very intensely flavorful. And so while taste bud sensitivity tends to go down, women during pregnancy also tend to have a heightened sense of smell. So that heightened sense of smell also affects food intake. And it affects a lot of other things. But a large majority of what we interpret as the taste of food is actually greatly affected by the smell of food. So food smells actually can, that increase in sensitivity can lead to food cravings, but probably most commonly it leads to food aversions. Okay. So foods that women might have previously enjoyed, they might be turned off to because the smell causes them to not enjoy the taste. Also, interestingly, women who are pregnant tend to have other common food aversions, including tea and coffee, fried foods, eggs, alcohol and smoking, which is obviously a good thing. Now, the important disclaimer in this is that the specific food intake of individual women is profoundly and ultimately influenced by the individual taste, cultural, and psychological factors for women. So while about 50% of women have an increased appetite during pregnancy, as we'll see in the next slide, nausea, especially in the first trimester, can be a significant problem for some women, causing actually a decrease in appetite and even a decrease in food intake. So about 90% or so of women who are pregnant at some point experience nausea or vomiting. Okay, so vomiting doesn't have to happen, but certainly nausea is very, very common during pregnancy. And usually that nausea and vomiting and or vomiting is happening within the first trimester, and there is a peak around 8 to 12 weeks, right, of the occurrence of nausea and vomiting. Now, symptoms usually resolve by about mid-pregnancy. About half of women who experience nausea and vomiting in pregnancy experience it in the morning or more at night. So either in the morning or more at night. Some have a biphasic nausea where it's both morning and night. And for some unlucky women, they just have a constant nausea throughout the day. And there is a term to describe extreme nausea in pregnancy. It's called hyperemesis. It's actually extreme nausea and vomiting during pregnancy. And hyperemesis really depends on, it's very individual. Some women are just more prone to it, but it tends to occur more commonly in multiple pregnancies. So the reason why so nausea and vomiting, the most well-established or the best theories behind it is the rise in HCG early in pregnancy. Because if you look at the rise and fall of HCG during pregnancy, it looks very similar to the rise and fall in nausea and pregnancy during nausea and vomiting during pregnancy. So HCG is thought to mediate at least some of this effect on the tendency to cause nausea. However, there is another factor that also contributes to nausea and vomiting in pregnancy, and that's the effects of progesterone on stomach motility. And we're going to see this in the next couple slides, but progesterone throughout the body reduces smooth muscle tone. And in the stomach, progesterone is going to reduce the contractility or excitability of the stomach, and that means that the emptying rate of food from the stomach into the small intestine tends to occur more slowly. So whenever food sort of lingers in your stomach for too long, that tends to also trigger nausea. So the rise in HCG, the early rise in HCG during pregnancy, along with the decreased gastric emptying time caused by progesterone, is thought to work together to cause this nausea and vomiting during pregnancy. Okay. Now the hormones in pregnancy are going to affect the GI tract really from mouth to anus. Okay, so it's really going to affect the entire GI tract. So if we look at consider the mouth for a moment, oftentimes pregnant women often have potentially a variety of dental problems. There's an old wives' tale that you'll lose a tooth for every child you have. So while pregnancy and pregnancy hormones certainly don't cause tooth loss or tooth decay, they certainly change the environment of the mouth, and that tends to lead to potential dental problems. So first of all, the gums in a pregnant woman tends to be very hyperemic. It tends to have a higher blood flow and be edematous and spongy and bleed easily. Now, all of these effects on the gums is really thought to be caused by estrogen. Estrogen tends to increase the blood flow to the gums in the mouth and cause all these changes. Okay. It also causes the connective tissue in the mouth, including in the gums, and also the other connective tissue areas in the mouth. It sort of changes the consistency of the connective tissue, especially as we go along during pregnancy. What we're going to find is estrogen and progesterone, a hormone called relaxin released by the placenta, are all going to change the connective tissue in the body, change the joint mobility, tend to make joints more mobile, hypermobile. And this is all in preparation for allowing the baby to be delivered, right? To allow the expansion of the pelvic cavity and allow for childbirth. But there are other consequences to that, right? So the gums bleed more easily. They're also more sensitive to abrasive foods and rigorous toothbrushing. Gingivitis and periodontal disease occur very commonly in pregnant women. Gingivitis, or inflammation or infection of the gums, occurs in about 30 to up to 100% of pregnant women. And it tends to begin around the second month of pregnancy, and it peaks around the middle of the third trimester. And part of this change in the susceptibility to inflammation and infection of the gums is the salivary glands start producing a more acidic saliva, and that tends to change the makeup of the bacteria that lives in the mouth, right? Potentially favoring bacteria that tends to cause gingivitis. Now, if we move away from the mouth and into the esophagus, leading to the stomach, what we find is, again, progesterone is decreasing smooth muscle tone. And in this case, it's decreasing the tone of the lower esophageal sphincter. Now, this increases the risk of acidic stomach contents refluxing into the esophagus, causing pain in the form of heartburn. And so heartburn during pregnancy occurs about 30 to 70% of the time. It tends to be something that starts around the second trimester, okay? And there are certain conditions that increase the intensity and the likelihood. So things like multiple pregnancy, obesity, excessive bending over, okay? So all of those things, multiple pregnancy, obesity, excessive bending over, it's going to increase the pressure in the abdominal cavity and increase the likelihood that the stomach is getting pushed on and the stomach acid moves into the esophagus, right? And then on top of that, there are certain foods that tend to increase or exacerbate the reflux. And it's all the same foods that you think about for exacerbating people, non-pregnant people who have GERD. Things like chocolate, alcohol, coffee, they all tend to even worsen even greater the effects of heartburn. So moving down into the stomach, what we find in the stomach is many changes. So I mentioned that progesterone lowers the smooth muscle tone in the stomach, and this tends to decrease gastric motility. So if the stomach is, the muscle movements in the stomach are happening less rigorously, that means food is moving through the stomach into the duodenum at a slower rate. So gastric emptying time is slower. Now, we just talked about the increased risk of heartburn, so that means acid going into the esophagus. So potentially as a compensatory mechanism for that, the acidity of the stomach actually tends to decrease during pregnancy. Then there's a decrease in both acidity and therefore pepsin activity, since pepsin is activated under acidic conditions. So the decrease in hydrochloric acid production by the stomach is thought to be an effect of estrogen. Okay? So as estrogen levels rise, the stomach starts producing less hydrochloric acid, and so the pH in the stomach tends to get tends to rise, tends to become less acidic. Now, this is not, the stomach content is still acidic, but instead of it being a 3, right? I'm making this number up, but instead of being a 3, 3 is a real number, but it may be a 5, right? So it's still very acidic. However, it's not as acidic as a non-pregnant stomach. Now, as a result of this decrease in hydrochloric acid production, the production of pepsin also changes, okay? And pepsin production goes down. Okay. Now, additionally, as progesterone works its magic on all our smooth muscle, it's also going to reduce the smooth muscle tone of the pyloric sphincter, which means that there's a greater chance for alkaline duodenal contents to reflux into the stomach. Okay? Now, that reflux of alkaline content into the stomach is going to contribute to that reduction in stomach acidity. Okay? And then finally, we also see an increase in gastrin production towards the end of pregnancy. So if you remember, gastrin was a hormone that is released by the lining of the stomach, and it does several things, but one of the things it does is it stimulates gastric secretion, so it stimulates the secretion of hydrochloric acid and things like pepsin by the stomach. Okay? And it also tends to increase stomach motility and also the motility throughout the GI tract, right? So throughout most of pregnancy, gastrin stays the same. But towards the end of pregnancy, gastrin levels actually tend to increase. And this additional gastrin is thought to be coming from the placenta. Now, that increase in gastrin is going to actually help counteract that effect of progesterone throughout the GI tract. Okay? So while progesterone tends to decrease smooth muscle tone and motility, gastrin towards the end of pregnancy is going to counteract that, right, and try to retain some motility throughout the GI tract.